So first, I would like to give you some background information on the three major molecular mechanisms involved in colorectal carcinoma oncogenesis. So the first major pathway is called chromosomal instability or SIM pathway. This pathway involves 75% of colon cancer oncogenesis. It is defined as the presence of gross structural aberrations such as deletions, insertions, and loss of heterozygosity, resulting in an altered karyotype. The most important genes involved are APC, TP53, and a few others. The second important pathway is microsatellite instability pathway, or MSI-high pathway. So this pathway is based on mutations or epigenetic phenomena in one of the DNA MMR genes or mismatch repair genes, MLH1, MSH2, MSH6, and PMS2, which leads to the dysfunction of the DNA MMR enzymes. So consequently, if there's defect in the machinery, then there's accumulation of DNA abnormalities, especially the mononucleotide or the dinucleotide repeats found throughout the genome, which are defined as microsatellites. So the MSI-high pathway is about 15% of CRC. And then the third pathway is the CpG island methylator phenotype, or SIMP pathway. That is also about 20 to 25% of the colon cancer. And you can see there's overlap between the latter two pathways. This is another way to look at colon cancer. If you have 100 colon cancer, 85 of them will be MSS or MSI low. And 1% would be due to syndromic condition like FAP, familial adenomatous polyposis syndrome. And then 84% would be sporadic. And then 15% of the 100 would be MSI high. And among those, 3% would be Lynch, and then 12% would be sporadic. So on the right of the diagram, you can see the BRAF mutations are heavily present within the MSI high CRCs, versus the KRAS mutations are heavily associated with the MSS type of tumors. Today we're going to focus on BRAF mutated colorectal cancer. So a little background on BRAF protein. BRAF is a serine threonine protein kinase in the MAP kinase signaling pathway. This pathway is very important in regulating cell proliferation, differentiation, and many other important functions. And dysregulation of this pathway underlies many instances of tumorigenesis. So on the right, you can see the receptor tyrosine kinase, including EGFR. When they are activated by signals, they will be phosphorylated and then transduce the signal down to RAS, a GTPase, which cycles between a GDP-bound inactive form and the GTP-bound active form. So when they are active, they will transduce the signal down to the RAF proteins as they heterodimerize or homodimerize, and then in turn transduce the signal down to MEK-MEK or and then ERK proteins. So this is the normal cascade. And when there are activating mutations happening in any of these steps, such as the EGFR or the receptor tyrosine kinase, RAS proteins, if it's constitutively active, or RAF, BRAF, constitutively active, then the cascade does not need any signal. So that underlies important mechanism for oncogenesis. So what do we know about BRAF mutations in CRC? So BRAF activating mutations occur in 5 to 15% of CRC. And BRAF mutations are usually mutually exclusive with KRAS mutations. So biologically, it makes sense to be very efficient because in the same pathway, the tumor doesn't need to have redundant, mutations in the same pathway. So dual RAS and RAF mutations occur only in 0.3% in one series and then 0.01% in another study series. In terms of the types of BRAF mutations in CRC, so there are actually three different classes of BRAF mutations. So class 1 and 2 are kinase activating mutations. So the majority of colon cancer has V600E mutation. In some series, it's up to 96% of all BRAF mutations in CRC. And then codon 601 or 597 may have mutations. So those two are the activating mutations. And then the third class is the kinase impairing mutation, usually at codon 594 or 596. So this slide here shows the mechanistic differences of these three classes. So class 1 and class 2 are constitutively active mutations where the RAS is actually inactive. There are no additional mutations needed, versus the class 3 is the kinase impairing, which does need the second hit upstream to form the tumor. Because, like I said before, V600E mutation is the predominant mutant form found in the CRC, up to 96% in some series. So we're going to focus the talk on V600E of BRAF. What are some of the clinical pathologic features of BRAF V600E mutated CRC? These are relatively distinct group of tumors. They tend to be more right-sided, tend to occur more in female, and then in older age patients. Histologically, they have more mucinous phenotype, more poorly differentiated, including the signet ring morphology. This may also be part of the MSI high phenotype because, as you know, the V600E is very associated with the MSI high status. And these tumors tend to have more peritoneal and nodal metastases and less lung metastases. The other feature of BRAF V600E mutation is that it's an exclusive feature of the serrated pathway due to its frequency in the majority of the serrated polyps, especially the sessile serrated adenoma or sessile serrated lesion, as they're called by the current WHO. But they're rarely present in conventional adenomas. So there is also a strong positive correlation between BRAF V600E and deficient mismatch repair protein status or MSI high status. So 40 to 60% of all MSI high CRC have BRAF V600E mutation versus only 7% of all MSS colorectal cancer have BRAF V600E mutation. So what is the importance of BRAF V600E mutational testing in CRC? Well, there are several reasons to do the test for the specific mutation. For one, it is an important biomarker for prognosis in CRC. Two, it is a biomarker along with RAS for anti-EGFR treatment. So BRAF V600E mutation makes response to anti-EGFR therapy highly unlikely unless given a BRAF inhibitor. And then third, it's a biomarker for some new therapy regimens on the horizon. So Dr. Basu Malik is going to go into detail about these points in the latter half of the talk. And then for our pathologists, I think we use this test in the setting of screening for Lynch syndrome a lot more in the setting of loss of MLH1 and PMS2 IHC. So now let's take a look at a case. So this is a 75-year-old man with a cecal mass. There's no family history of colon cancer. And the biopsy showed, as you see here, an invasive colonic adenocarcinoma, moderately differentiated with mucinous features. For all newly diagnosed colorectal cancer at our institution, we perform upfront MMR or mismatch repair protein immunohistochemistry. So that would include 4 proteins, MLH1, PMS2, MSH2, and MSH6. The other test of choice that you can do is using the PCR molecular testing for MSI status. These tests are considered interchangeable, and there is very, very small amount, less than 1% probably, that you would have discordant results. So to interpret the MMR results, you would truly need to look at 2 things. One is your internal positive controls, which are shown here, such as the lymphocytes and the stromal cells have deep dark brown staining. And then the second thing is to look at the tumor cells that they show loss, complete loss of the protein staining. So this has loss of MLH1 and PMS2. The other 2 proteins, MSH2 and MSH6, as shown here, show no loss of staining. So it's the normal pattern, or we call intact staining pattern. I want to spend a couple minutes on the immunohistochemistry staining patterns for MMR proteins with respect to interpretation for Lynch syndrome, because as pathologists, we deal with this almost on a daily basis. So as you know, MLH1 and PMS2 form a complex, and MSH2 and MSH6 form a complex. So majority of the cases, if you lose MLH1, you automatically lose PMS2. And the same thing goes for MSH2. If you lose it, you automatically lose MSH6. However, the vice versa is not true, meaning you can have isolated loss of PMS2 or isolated loss of MSH6. So here are some patterns, majority of the patterns that we see for these stainings in colon cancer. So if all 4 proteins show intact nuclear staining in the tumor cells, then we call them proficient MMR. But you cannot exclude the possibility of Lynch because there are rare germline point mutation that can show intact epitope staining, like the IHC staining. However, the gene function may be lost, or there might be some other rare gene mutations that may not show loss of these 4 proteins by IHC. So always correlate with the clinical history, family history, and like I say, majority of the cases it's not Lynch, but there might be rare instances that it occurs. And then the second pattern is the loss of both MLH1 and PMS2. So this is deficient MMR, and there are 2 reasons for this. One is the MLH1 promoter hypermethylation induced silencing of the promoter, and then the other one is due to the MLH1 germline mutation. And the third pattern is loss of both MSH2 and MSH6, and it's also deficient MMR, most likely due to MSH2 germline mutation. So isolated loss of PMS2 most likely is the germline mutation, Lynch syndrome. However, there are rare MLH1 mutation may also have this pattern. And sometimes post-treatment, post-chemotherapy, colon cancer specimens can show this. And the other isolated loss, MSH6, also most likely due to MSH6 germline mutation. However, there is also post-therapy cases reported. So these are the majority of the patterns that we can see. So for our patient in this case, there is loss of MLH1 and PMS2 and intact or retained MSH2 and MSH6 stainings by immunohistochemistry. So it's a right-sided colon cancer in an older gentleman. The reason for this could be either the MLH1 promoter hypermethylation, which would be sporadic, or the MLH1 germline mutation, possibly Lynch syndrome. So the question is for the testing algorithm, what is the next step of testing to differentiate these two possibilities, Lynch versus sporadic cancer? So the next step testing is either BRAF mutational analysis or MLH1 promoter methylation studies. Either one will do, and in this case, we did BRAF mutational analysis, and it showed BRAFV600E mutation. So in combination with the clinical history, no family history, age, this is considered sporadic colon cancer. This brings me to the reasons, the important reasons behind BRAF testing in colon cancer. As we said in the beginning of the talk, BRAF is a very important prognostic factor, so it predicts worse prognosis overall for colon cancer. And it's also a very important predictive biomarker for multiple different therapy regimens. So Dr. Basul Malik is going to talk in detail about these. But from pathology perspective, we deal with this test probably more in the setting of screening for Lynch syndrome, especially in the loss of MLH1 and PMS2 immunostains. So this test can differentiate in majority of the cases, probably 98 to 99% of the cases, between the sporadic MLH1 hypermethylated CRC from the germline mutation caused Lynch syndrome CRC. So the presence of a BRAF mutation in the setting of loss of MLH1 and PMS2 strongly favors this is a sporadic CRC, like shown in our case. However, contrary to what was believed years ago, its absence does not completely exclude the risk of Lynch. So there are about 1 to 2% of cases which have Lynch syndrome but has BRAF mutations. Overall, it is a very cost-effective method before sending the patients for germline mutational testing. Just to give you some historic perspective, so this is the paper published in American Journal of Gastroenterology in 2014 for universal screening for Lynch syndrome by tumor testing. As you can see, we started with a surgical specimen for colon cancer. You can either go for MSI testing or IHC testing, as I have stated earlier. So if you do IHC testing for these 4 proteins, if you have loss of MLH1 and PMS2, then the next step would be BRAF testing and or promoter hypermethylation. And the presence of the mutation at that time was considered that this person does not have Lynch. It's going to be sporadic and no further testing would be done. But then if there is absent BRAF mutation, then there are still 2 possibilities. Then the patient needs to be referred to genetic counseling if there is strong family history, clinical concern for Lynch syndrome. So the patient may undergo germline testing after that. A recent very large analysis comparing the BRAF-V600E mutation frequency in both the Lynch syndrome confirmed patients as well as the sporadic MSI high patients showed that actually a very small percentage, 1.6% by the study, of Lynch syndrome MSI high CRCs show BRAF-V600E mutations. And then when age data were available for these patients, 86% of them, 6 out of 7, were from Lynch patients who are actually younger than 50 years of age at diagnosis. In contrast, 92.3% of BRAF V600E positive sporadic MSI high cases were from patients aged older than 60 years. So this result interpretation could be refined based on the patient age. So this flow chart here shows the current algorithm that we use to screen for Lynch syndrome in colorectal cancer at our institution. I just want to make a point that even if in the loss of MLH1 and PMS2 cases, the BRAF V600E mutation is positive, if there is a strong clinical suspicion, family history, younger than 50 years of age, we still cannot rule out Lynch in those settings, and additional genetic counseling will be useful in that setting. So the point is we do not want to miss Lynch patients. This slide here shows the current NCCN guideline for colorectal carcinoma, KRAS, NRAS, and BRAF mutational testings. So all patients with metastatic colon cancer should have tumor genotyped for RAS and BRAF mutations, either individually or as part of an NGS panel. And BRAF V600E mutation makes response to panitumumab or cetuximab highly unlikely, these anti-EGFR receptors, unless given with a BRAF inhibitor. And then the BRAF V600E mutation testing via immunohistochemistry is also an option. So testings for these mutations should be performed only in laboratories that are certified under the Clinical Laboratory Improvement Amendments of 1988, so the CLIA 88, as qualified to perform high complexity clinical laboratory molecular pathology testing. And then the last point is that the testing can be done on either the primary or the metastases or both. So literature has actually shown that the mutational profiles are similar in both specimen types. In terms of choice of testing methodologies, so there are several accepted methodologies for BRAF testing. Center sequencing for individual gene testing, a big NGS panel, which includes BRAF, as well as the immunohistochemistry using antibody against BRAF V600E mutation. So these are all acceptable. The choice of methods really depends on the institution or practice preferences. So it's really a multidisciplinary approach and decision, meaning the pathologists, oncologists, radiologists, gastroenterologists, surgeons have to kind of sit down together and then try to figure out what would be the best to go about. In terms of the IHC, so here are some sample images from published papers. I listed several that are dealing with the sensitivity and specificity of IHC for detection of BRAF V600E in colorectal cancer when compared to the gold, standard testing, the sequencing. And you can see the sensitivity ranges between 94 and 100%, and specificity ranges from 95 to 100%. So these are acceptable methodologies. So again, it really is the decision made by the institution or practice.
Just about a decade ago, molecularly directed therapy for metastatic colorectal cancer was just based on KRAS status. KRAS wild-type tumors could be treated with EGFR inhibitors, and the others were not susceptible to that treatment. In the last decade, from 2011 to the present, the biomarker testing in colorectal cancer has really evolved, and so has the molecularly directed therapy for metastatic colorectal cancer. As you can see in this pie chart, just knowing that one has, metastatic colorectal cancer with RAS mutated or wild type is not enough. We need to know, when we see a patient with metastatic colorectal cancer, we really want to know exactly in which segment of the pie chart our patient belongs, not only for prognosis, but also for treatment planning purposes. This slide summarizes the various treatment pathways that are approved and followed for different biomarker positive metastatic colorectal cancers. You can see it's not just one disease anymore. It is a combination of multiple diseases because the treatment is quite varied, and so is the prognosis. Today we will just talk about the BRAFV600 mutated colorectal cancer and concentrate on first-line therapy, second-line therapy, and also certain subdivisions of the BRAF mutated colorectal cancer population. Let us start exploring different treatment options that are available for this patient population by starting with a typical case of BRAF mutated colorectal cancer. So my patient, WJ, is a 52-year-old Asian man with past medical history only significant for hepatitis B, who presented to his PCP with complaints of worsening dyspnea on exertion and weight loss of about 10 pounds over just 2 months. Patient had never had a screening colonoscopy before. Just being 52, he had kind of procrastinated on it. Initial workup showed iron deficiency anemia. Further workup with colonoscopy and imaging with CT scan showed mass in the ascending colon with innumerable liver lesions and bilateral lung nodules. Biopsy of the liver lesion was positive for poorly differentiated adenocarcinoma. The IHC markers were consistent with colon primary, being CDX2 positive, CK20 positive, CK7 negative, and the tumor by IHC was MMR proficient. The molecular profile showed the tumor to be KRAS wild type, NRAS wild type, BRAFV600E mutated. What, if any, would be the effect of his molecular characteristics on his prognosis and the treatment of his colorectal cancer? Unfortunately, it's a well-known fact that patients with BRAF mutated colorectal cancer have a much poorer prognosis than patients with BRAF wild-type colorectal cancer. As you can see, in the 80405 CALGB study, the BRAF mutant patients had a median overall survival of 13.5 months as opposed to BRAF wild-type, which had a median survival of 30.6 months. So right off the bat, we know our patient is presenting with an unfavorable characteristic, portending a poor prognosis. The TRIBE study was the first phase 3 large randomized study which treated patients with a more aggressive regimen, a 3-drug regimen, as opposed to a usual doublet used in metastatic colorectal cancer patients. Patients were randomized to be treated with FOLFOXIRI plus bevacizumab versus FOLFIRI plus bevacizumab as first-line treatment of patients with metastatic colorectal cancer. This is of real significance, especially in the BRAF population, given that are they have a poorer prognosis than the rest of the colorectal cancer patients. Graphs of overall survival and progression-free survival from the TRIBE study reiterate the fact that the BRAF mutation positive patients, the red line, do have a much worse overall survival and much worse progression-free survival. And perhaps in this population, the toxicity of adding a third chemotherapy agent is worth the benefit because of poor survival with just doublet with biologic agent. As you can see in this slide, the subset analysis of the different populations by their molecular characteristic from the TRIBE study shows that adding the third drug, like FOLFOXIRI plus bevacizumab, as opposed to FOLFIRI plus bevacizumab, did have a better overall survival and a trend towards better progression-free survival in this population, where actually the toxicity is worth the benefit, given that otherwise these patients do so poorly with upfront double agent chemotherapy with biologics. Following the data from the subset analysis from the TRIBE study, most physicians tended to give FOLFOXIRI plus bevacizumab in the population of BRAF mutant patients who had good performance status, young age, lacked significant comorbidities. The FIRE 4.5 study was the first study to actually treat patients with BRAF mutated colorectal cancer prospectively by comparing two regimens. Both of them had triple drug chemotherapy backbone, but the main comparison was between cetuximab versus bevacizumab. Because KRAS mutation and BRAF are mutually exclusive, all BRAF mutant patients are KRAS wild type, hence the thought of trying a different biologic to see what would be better for this population upfront. As you can see, the progression-free survival favored the FOLFOXIRI plus bevacizumab arm with a median PFS of 10 months as opposed to a median PFS of 6.3 months in the cetuximab arm. Progression-free survival was improved in the bevacizumab arm. There was also a trend towards improved objective response rate and overall survival with the bevacizumab biologic rather than cetuximab in the FIRE 4.5 study. However, the objective response rate and OS did not meet statistical significance. The conclusion from the FIRE 4.5 study was that it was the first randomized study prospectively investigating just BRAFV600E mutant metastatic colorectal cancer in first line, and that there FOLFOXIRI plus cetuximab did not induce a higher response rate. In fact, FOLFOXIRI plus bevacizumab induced a longer progression-free survival and was in general more preferable than FOLFOXIRI plus cetuximab in first-line setting. It also highlighted the fact that only 83% of patients reached 3 cycles of chemotherapy and got a follow-up CT scan, which underlines the very poor prognosis of BRAF mutant metastatic colorectal cancer and emphasizes the importance of actually designing trials for just this patient population. Now that I have repeated over and over again about the poor prognosis of this patient population, it's time to see some light in at least some specific segment of the BRAF mutant metastatic colorectal cancer population. So this is my second patient, 73-year-old, very pleasant Caucasian woman with a history of ovarian cancer, Hashimoto's thyroiditis, previous Lyme disease, who presented to the hospital after outpatient labs with her PCP showed her to have a hemoglobin of 4.8. She had been experiencing progressively worsening shortness of breath and fatigue over the last several months, had lost about 30 pounds over 6 months. She initially attributed these symptoms to her chronic Lyme disease, but had blood work done by her PCP that showed severe iron deficiency anemia. Her previous colonoscopy was over 10 years ago, and she told us that she was told at that time that they could not see far into her colon due to suboptimal preparation. Workup on that admission for her iron deficiency anemia did not show any abnormalities in her upper endoscopy. However, the colonoscopy showed a mass in the ascending colon, following which patient got a CT of chest, abdomen, and pelvis, which showed ascending colon wall thickening with adjacent lymphadenopathy up to 1.1 centimeter, but there was no evidence of metastatic disease. However, the CT scan also showed a large bladder mass arising from the bladder roof. She underwent cystoscopy with transurethral resection of bladder tumor in February 2021 with complete resection of the tumor. Subsequent pathology showed high-grade urothelial carcinoma without muscular invasion. Yes, thankfully, that was, a relatively superficial tumor. Of note, on finding a genitourinary cancer and colon cancer at the same time, we asked her family history as a routine, but also emphasized on it more. And she had a family history of renal cell cancer in her father and one of her maternal uncles. Her brother had a suspicious kidney mass that was being actively followed by his physicians. Her mother had squamous cell carcinoma of the vulva. Given her personal history of a GYN cancer and now synchronous presentation of bladder cancer and colon cancer, of course, we had started hoping that she would be MSI high. Colonoscopy with biopsy of ascending colon mass showed poorly differentiated adenocarcinoma with deficient MMR protein. As you can see, MLH1 and PMS2 were lost. However, subsequently on molecular analysis, we saw that she was BRAF mutation positive, which indicated that this likely was somatic and not a germline MSI high tumor. However, one has to go back to the patient's own history and the patient's family history, which made us think that maybe this is one of those rare 1% cases where in a Lynch syndrome one can even find BRAF mutation. However, common things being more common, although we thought, given her personal and family history, this could be Lynch syndrome and did send for germline mutation studies and sent for IHC on MMR IHC on her urothelial cancer. Of course, common things being more common, her urothelial cancer was MMR proficient and there was no evidence of Lynch syndrome. Hence, she stuck by the rule that if BRAF mutated, then the MSI high is likely sporadic rather than germline. Given that there was no distant metastatic disease noted in her CAT scan, patient was taken to the operative room for curative intent resection of her ascending colon mass, but was detected to have distant lymph nodes and peritoneal metastases, which were too small to be detected in CAT scan while in the OR. Hence, she has metastatic BRAF V600 mutated colorectal cancer, which is MSI high. What would be her optimal regimen in first line? Hence, my patient fell into another subcategory of BRAF mutant patients. 1/4 of BRAF V600E mutated metastatic colorectal cancer patients have microsatellite instability high. And 1/5 of MSI high metastatic colorectal cancer display BRAF mutation, both of which are associated with poor survival and limited response to chemotherapy with or without targeted therapy. Hence, the BRAF mutation actually causes hypermethylation of the DNA mismatch repair gene, leading to the MSI, somatic MSI characteristic of the tumor. The therapeutic landscape of patients with MSI high or mismatch repair deficient metastatic colorectal cancer has transformed by the development of immune checkpoint inhibitors, and hence, though these patients have BRAF mutation positive colorectal cancer, their prognosis is better than ones with microsatellite stable BRAF mutated colorectal cancer. The Keynote 177 study was a phase 3 randomized study of pembrolizumab versus chemotherapy for microsatellite instability high advanced colorectal cancer. And this study enrolled patients irrespective of whether they were BRAF mutated or BRAF wild type. As you can see, there were about 307 patients who were randomized to receive either pembrolizumab for up to 35 cycles or investigator's choice of FOLFOX or FOLFIRI along with biologic of either bevacizumab or cetuximab or none, and which were continued until unacceptable toxicity, disease progression, or patient or physician withdrawal decision. Optimal crossover to pembrolizumab for up to 35 cycles for patients with the centrally verified progressive disease on RECIST in the chemotherapy arm was allowed. As you can see, the immunotherapy arm had a statistically significant improvement in progression-free survival of 16.5 months when compared to the chemotherapy arm with 8.2 months. The duration of response was also remarkably better in the immunotherapy arm, with the duration not being reached at the time of presentation during the GI Cancer Symposium in 2021, as opposed to the median duration of response being 10.6 months in the chemotherapy arm. As you can see in this slide, up to 36% of patients crossed over from standard of care to the pembrolizumab arm on progression, and almost a total of 60% of patients actually crossed over and did receive immunotherapy in subsequent lines of therapy in the Keynote 177 study. Despite the 60% crossover to immunotherapy in the standard of care therapy arm, the progression-free survival 2, which is time from randomization to progression on next line of chemotherapy, still favored the immunotherapy arm as first-line treatment for this population. Hence, in summary, pembrolizumab provided a clinically meaningful and statistically significant improvement in progression-free survival versus chemotherapy in patients with MSI-high metastatic colorectal cancer. Responses were more durable with pembrolizumab versus chemotherapy, and pembrolizumab versus chemotherapy provided clinically meaningful improvement in PFS2 in patients with MSI-high CRC. The safety profile was manageable, and this data supported immunotherapy or pembrolizumab as new standard of care for first-line therapy in patients with MSI-high metastatic colorectal cancer. The data from Keynote 177 trial, which demonstrated superiority of pembrolizumab, was also applicable to my patient with a BRAF mutational status, as the superiority of immunotherapy in the MSI-high population was noted regardless of BRAF mutation status. Hence, immune checkpoint inhibitors should be considered as standard first-line therapy for patients with MSI-high BRAF mutated metastatic colorectal cancer. My patient, Ms. NW, remains on single-agent PD-1 inhibitor with partial response as her best response, now going on 11 months of palliative therapy. So unlike patient 2, patient 1, WJ, did not have MSI high. He had just BRAF mutation with microsatellite stable disease, and hence he was started on standard of care therapy with FOLFIRINOX and bevacizumab. Unfortunately, after 6 months of therapy, patient showed evidence of progressive disease in his liver lesions. Given young age and minimal comorbidities, he still remained at a PS of 1 and had a good nutritional status. So what would be his second-line therapy in the standard of care setting in today's day and age. The answer for his subsequent line of therapy comes from the results of the Beacon study, which was a phase 3 study in second line or third line BRAF mutant metastatic colorectal cancer. Uh, in colorectal cancer, although BRAF mutant patients are EGFR wild type, just blocking EGFR does not work because of upregulation of downstream pathways. Hence, EGFR has to be blocked with downstream pathway blockers like a BRAF blocker and a MEK blocker. So, this trial utilized blocking the pathway in multiple sites. So patients were randomized into 3 arms. First arm encorafenib plus binimetinib plus cetuximab, which is essentially a BRAF blocker, a MEK inhibitor, and an EGFR inhibitor, versus a doublet therapy, which is just the EGFR and the BRAF inhibitor, versus standard of care, which is chemotherapy with EGFR inhibitor, either FOLFIRI or irinotecan. The results showed superiority of the targeted therapy arms when compared to chemotherapy in combination with EGFR inhibition. However, it was surprising to see that the doublet performed as good as the triplet and gave lesser toxicity than the triplet therapy. Hence, FDA approved encorafenib and cetuximab doublet for second line beyond treatment in BRAF mutant colorectal cancer based on the studies, based on the results of the Beacon study. The median overall survival for both the doublet and the triplet arm was 9.3 months, whereas that of the control arm with chemotherapy and cetuximab was just 5.9 months. Predictably, the triplet arm had much higher grade 3 toxicities. Overall, about 66% of patients had grade 3 toxicity in the triplet arm as opposed to 57% in the doublet arm and about 64% in the chemotherapy backbone arm. The main side effects noted were diarrhea, nausea, vomiting, abdominal pain, and dermatitis like rash together with fatigue. And all these side effects were much lower with the doublet than with the triplet. So it was a win-win because the doublet worked as good as a triplet, it gave less toxicity, and of course was much more cost effective than adding a third drug. So the conclusions from the Beacon study were that patients with BRAFV600E mutant colorectal cancer had poor prognosis with second or third line, with the control arm in both Beacon and S1406 study reaching only a median overall survival of about 5.9 months. Encorafenib and cetuximab was established as standard of care for second line plus BRAF mutant metastatic colorectal cancer based on the study. And it was proven that the doublet would be preferred to the triplet because there was no advantage of adding the third drug other than increased toxicity. However, would this regimen be a better option in first line for this patient population? This was being studied at the time of Beacon trial in another trial called the mCRC study. Is encorafenib cetuximab the appropriate backbone now to evaluate additional therapy? Yes. Good response of targeted therapy in this patient population in second and third line setting, investigators were encouraged to see if this good response would give a better response than the combination chemotherapy that was sort of standard of care in first line setting for this population. And hence the anchor CRC study was first line encorafenib plus binimetinib plus cetuximab in BRAFV600E population. Although one is discouraged to do cross-trial comparisons, one can't help but see that the response rate in first line of this triplet therapy was really high at 48% as compared to the Beacon trial, where second and third line patients were treated with the same treatment, where the triplet had a response rate of about average 27% and the doublet of about 20%. The responses did not last long. Median progression-free survival was comparable to expected chemotherapy or second or third line BRAF targeted therapy, with a median PFS being about 5.8 months with confidence interval between 4.6 to 6.4. Not only was the duration of response not impressive, the median overall survival was comparable to expected outcomes with first-line chemotherapy, with the Anchor CRC study showing a median overall survival of about 17.2 months. Hence, after taking into account the TRIBE study, the Beacon study, the Anchor study, as well as the Keynote 177 study, the take-home points in general are that the Anchor CRC trial had good overall response rate, but the PFS was similar to second-line Beacon trial. Overall survival for BRAF mutated patients was similar to first-line chemotherapy when compared to 80405 trial. Encorafenib and cetuximab should be considered the standard of care for second line and beyond in treatment with BRAFV600E mutated colorectal cancer, and immunotherapy should be considered for first line therapy in BRAF mutated MSI high colorectal. Future directions in which the treatment of this patient population can be further improved are the combination of BRAF inhibitor and EGFR inhibitor with chemotherapy, which is being done in the Breakwater study, and also consideration of bringing these targeted treatment or at least testing them in earlier stages, like in stage 3 colon cancer, where we don't have specific or more aggressive guidelines for adjuvant therapy for patients with BRAF mutated stage 3 cancer. However, there is enough data to prove that they have inferior survival when compared to BRAF wild type colorectal cancer patients. Thank you very much for your attention.